Actually, I would agree with the 95% of what Michael has said. We're just trying to move into the future. We know that this is a problem, and we know it's a serious problem, and he's made this case. So we're actually on the same level. The problem, Michael, if we can get this to go forward, is the ball game is over. It just is over because of the new instrument that's now available. We are the big hitters in the risk of DVT, which, as Michael has pointed out, both total hip, and hip fractures. We're such big hitters that we have to use some prophylaxis in all these patients because they're all at high risk. Now, here's how most physicians look at bleeding and DVT. They look at it as a teeter-totter in which you're looking at both equally, but that's not how orthopedists look at it. Orthopedics look at it in this manner. If you have a DVT or a PE, that's an act of God. If you have a bleeding, it's an act of the orthopedic surgeon. So taking that this is the way we are, maybe this is not the way we should be, but this is the way we are, then up till now, pharmacological prophylaxis has been the treatment of choice. However, orthopedic surgeons hate drugs. They hate them because of the risk of bleeding and therefore are looking for adequate mechanical devices if they should be available. So much so that the AAOS, there's a new set of guidelines. They've just ruled out even thinking about DVT. All they care about is PE so that they can use whatever they would like, because none of the studies have been powered to show a difference in PEs. Well, let's just assume for the moment drugs are gone. There's a paradigm shift. It's coming. In fact, it's arrived. Mechanical methods of prophylaxis, we do have 1A ratings, the ACCP guidelines, but only at very, very high risk of bleeding, or if we actually have the proper use and optimal compliance. So compliance is a very big issue in terms of mechanical devices. And so far, the mechanical devices you can't wear when you're up and walking. You can't take them home. They're not portable. They're not really usable when you go down to get a CT scan or you go down to your PT and so forth. You can't take these devices with you. The theorized mechanisms of mechanicals have been known for a long time: increased venous blood flow, emptying, release of endothelial-derived relaxing factor urokinase, and the systemic endogenous fibrinolytic effect. So this is not new information. They also prevent DVT as well as potential PE. Advantages: they do not increase the risk of bleeding. They can be used in patients with high bleeding risk. They already showed some efficacy. They may enhance the effectiveness of anticoagulation, and they may also reduce leg swelling. But there's limitations to these devices up till now. They have not been as intensively studied as the pharmacological agents. There's no established standards have been done. Many of the mechanical devices have never been assessed in any clinical trial, and therefore clinical trials are terribly important, and the high-risk groups are probably less effective than anticoagulant thromboprophylaxis. What about a new device? Mechanical compression devices, we know, are almost complication-free, particularly the bleeding issue. We know that the effectiveness has to do with how much time they're worn, and we have to ensure that the patient actually is not impeded if they're using a device in their ambulation. Well, let's look at this new device, ActiveCare with synchronized flow technology. It's miniature, it's portable, it's battery-powered. You can use it in the hospital, out of bed, and out of the hospital, whichever you prefer. Triggers compression synchronization with your respiratory phase. As you inspire, your right thoracic pressure goes up, your right heart fill goes down, so it doesn't pump during that phase. It only pumps during the expiratory phase when your right heart is filled the best. It provides this natural phasic venous flow, and the patient compliance can be mounted on an LCD that's actually right in the front of the device. So the patient knows how long they're wearing it, and the doctor knows how long they're wearing it. This is what it looks like. This is the technology behind the device. There's one little chamber that has this device that coordinates with your phase of respiration. Okay, this is a Mark Fronson study from the Cleveland Clinic showing that this particular device, because of that, works better than other devices. Popliteal level, 66%. At the SDC level, 72%. So it works better than other devices. This is the first small study, Gelfer et al., out of Israel, in which they had a zero rate. Of course, these numbers are really, really small. So we were interested in doing a multi-center randomized prospective study to see if this thing really worked to that degree. All primary total hip arthroplasties, same exclusion factors as the pharmacological trials. And what we did with them is use the CET device, plus if you wanted to use aspirin, and many patients the doctors were using aspirin, against enoxaparin, the standard worldwide. Enoxaparin now has been tried in 140,000 patients worldwide in terms of prospective studies. The methods, treatment of 10 days with either of these, and we had bilateral duplex ultrasound done on day 10 to 12, compliance rate checked, the CEC device, how many hours did they actually wear it. We put the CEC device on in the OR, and then half of the patients received aspirin. That was a protocol of the physicians. The low molecular heparin group was just like in standard studies. 3 months post-op, we looked at them also clinically for signs and symptoms of DVT and PE, so we followed all these patients for 3 months. The results were exactly the same as far as DVT prevention, whether using enoxaparin or the CECT, and half of those, aspirin alone or with aspirin, those were unchanged. So it didn't make any difference, as it does in all studies, whether you use aspirin or not. There were no fatal PE or deaths. Major bleeding in the CECT, which you would expect, is 0. And the low molecular weight is exactly what the rest of the study showed, about 4%, using the same definition. Compliance, 86% of the time. The mean hours worn was 219 hours, or an average of 20 hours a day for 11 days. And in conclusion, the CECT has similar DVT rates to enoxaparin, significantly less major bleeding events, in fact, 0. The ball game, Michael, is over. You don't need to use pharmacological agents anymore. Thank you.